Welcome to the latest episode of MQ's Open Mind. Craig and I are delighted to welcome today. We've got another fantastic guest. We've got Jenny Okolo, and Jenny is an occupational therapist in mental health, particularly in the forensic end of things in criminal justice. And we'll be hearing a lot about that today. But Jenny's also a speaker, and we'll hopefully touch on your fantastic TED Talk from last year, 2022, I think.
Yes.
And also is founder of SASA. Get clarification from Jenny means it's healing in Japanese. We'll be hearing a lot about all of those and more. So welcome to our podcast, Jenny, and thanks for coming.
Thank you so much for having me. I'm really excited to be having this conversation.
Brilliant. So, what we try and begin in the podcast is really take people through a sort of narrative or a journey, or your mental health journey. So do you want to take us back to sort of where it all began, so to speak, in terms of, because obviously you've moved into mental health over your career?
Yeah, so I suppose my interest in mental health stemmed from growing up on an estate and seeing a lot of people, maybe walking in the streets. My neighbor in particular who had a mental health condition, also personal experience in terms of like my uncles and family who had undiagnosed mental health conditions. Like we always knew that there was something not quite right in a sense of an overt observation of mental illness. And I was always sort of curious as to how people maybe got to that point, what causes it, why is it that some people are diagnosed, some people aren't. So that curiosity led me into wanting to find out more about mental health, and knowing that I wanted to have a career that was health related, but I wasn't sure, in particular what kind of field. And I remember, like, it's quite funny actually. A couple of years ago, this is when Waterloo Road, I don't know if anyone knows about the show Waterloo Road, was quite popular back in my time. And
You're so old, Jenny.
oh no. I hope people will remember this, but there was a particular episode where one of the characters, I think his name was Josh, was experiencing a psychotic episode, and that was the first time I heard about schizophrenia. And they touched on, how it began for him. I think he was on drugs, and there was several different factors that contributed to his mental health declining. And I just found it so fascinating. I thought, oh wow, there's actually a name for these type of conditions. And then whilst I was in school, I did a shadowing experience for one day at a psychiatric hospital that wasn't too far from my house. I suppose that's where the doors opened for me. Like I was thinking, okay, this is where I want to work in. I managed to shadow an occupational therapist, and I saw the way that she was working with the patients, and it had a good balance of the clinical aspect, but also the creative, and making sure that the care was very individualistic. So in a nutshell, that's how my interest started and how I sort of began to learn more about the field that I wanted to get into.
Yeah, no, great. So just going back a wee step there. So where did the placement come from then? So did you say at school?
Yeah, so this was in sixth form.
Yeah.
My school had links with hospitals like King's College and Maudsley. So Maudsley is a psychiatric hospital that I was able to spend a day at. Of course, a day is, it's quite short, but it was enough to make me realize that this was the area that I wanted to go into. I believe, yeah, I was actually one of the only students who wanted to go into that field. So for me, it was quite difficult, especially when it came to applying for university. Nobody knew what occupational therapy was. I would say even now, like I would say maybe now more so occupational therapy is being more known about. But back in my time, it was, oh, you're either going to become a nurse or a doctor if you want to work in the healthcare industry. So it took a lot of, me doing my own research and going out of my way to maintain those links that I did at the hospital.
And when I think back to when I was at school, I had no idea. I don't think I'd even heard of it. Well, probably had heard of occupational therapy, but I didn't know much about it. I do think definitely now the profession is more established.
Yeah, it's definitely getting more established. I think some people do confuse it with, well, either physiotherapy
Yeah.
or occupational health. So I do find myself having to explain sometimes, what occupational therapy is, which is all about supporting people with their independence. We work in both mental health and physical health community. So you will see us everywhere, but we are part of the NDT in most cases, and work in clinical type of settings, and also prisons, which I'm sure
Yeah,
we'll
we're
talk.
going to get on the prison. So yeah, occupational therapy, a key role in multidisciplinary teams, as you say, MDTs. But so in terms of where you most find occupational therapists in mental health, is what in child and adolescent services and adult rather than forensic, I'm assuming, or the criminal justice?
Yeah, so you'll mainly find OTs, so occupational therapists in CAMS, so working with young people in hospital settings or in the community as well, and in adult and older adult, settings, hospital settings and community settings. I'll say also schools as well. There are a lot of occupational therapists working in pediatrics and again with young people. There are so many, and that's also one of the main reasons why I chose this particular career, because I knew that if I got bored of one area that I was in, there were so many options for me to go into that piqued my interest.
And so in terms of the training for occupational therapy, so I assume the training it covers both physical health and mental health. And then do you go down a specialization in mental health or not? And then maybe can you tell us how you then moved into the criminal justice system?
Yeah, so occupational therapy is you study it for 3 years if you're doing the undergraduate. You can do a master's, but that would be 2 years. And you are dual trained. So you are trained in physical health and mental health. So everything. You do your anatomy, physiology, all that kind of stuff. I do know that now that this wasn't available during my time, but they do have apprenticeship schemes now. So you can work and you can obtain a degree at the same time. It does take a little bit longer, but at least it adds a bit more flexibility. So when I was doing my degree, I went to Oxford Brookes University. It was a combination of coursework, exams, but the main thing was placements, which is really important because that's how you get to hone in on your skills and get to kind of feel out what area suits you best. So my first placement, it was in the post-polio clinic. Again, I had no clue about this. So, it was actually a split placement, post-polio and neurology. Which was great, but I kind of knew that I didn't really want to go into that physical health sector. And then my second placement, and that was my first indication of, working in the criminal justice system alongside the NHS, was in a secure hospital. It was a medium secure hospital. And again, like initially I did have my reservations because I did research on what a secure hospital means, what kind of clients you tend to work with. But it actually ended up being such an amazing placement for me. And that's when I suppose that's where it began in terms of understanding that even within mental health, there are so many different areas that you can get into. And in my third placement, because I really enjoyed my second placement, my third placement, they sent me to a high secure hospital called Broadmoor. And again, I did have my reservations, but I would say it was by far the best experience I'd ever had, because it challenged my initial assumptions that I had about, these type of settings and working with criminals or people who had like long-standing forensic history. But when I went in there, of course, you do meet patients who are very, very unwell and very high risk. But I was more so intrigued about the type of work that was happening to support these patients. So, I was part of the OT team. I was seeing the different groups. They had a recovery college. I was working with a particular patient who, obviously on the supervision, who was doing these amazing drawings, and I thought, oh my gosh, like why doesn't the world know about this? Like, why isn't this in the papers? So it was such an amazing experience, like just seeing the journey and seeing that there is actually hope for people who are, even extremely unwell or extremely high risk. So I suppose that's where it began for me. Like I said, at that moment, once I finished, I said I wanted to work in forensic mental health.
Yeah, and so then you graduated.
Yes.
And so where are you? What sort of jobs have you been doing since that?
Yeah, so I graduated, and I had the opportunity to go back to my second placement, which was actually under the same trust. So to work in the medium and low secure services as an occupational therapist. I was given an award to look after from the OT aspect, and again, it was such a great experience for me. I also spent some time working as a care coordinator in the community. So that's what I mean in the sense of, as an occupational therapist, there's so many different opportunities for you to work in different settings. And then I sort of I really did miss the forensic element. And I said, let me just jump in and work in a prison. And that that was a very interesting experience. And also working in mental health, it can be just challenging in general, even as a health professional, because you might hear things, you might see things that might be triggering. But working in a prison was also the same as well, because it's not a hospital setting. You are working with a regime that's not necessarily clinical. And, we are a small team. I remember there were only 3 of us in the OT team, and I was the manager there. And, even, we didn't have like a clinic or anything. We had to go into the wings. And as you can imagine, the wing, it's very narrow, and the rooms are often not adequate enough for you to have like sessions and to assess people. So I found time and time again, there were so many different obstacles for me to face. So that was challenging, but it did teach me to, be more flexible and how to work with the different agencies, like, the governors there, and have conversations to try and enforce change. So I actually managed to secure a budget to redevelop the day center. So the day center it looked horrible. Like, it was all blue. There was barely any equipment in there. And, with the permission from the governors and the support from them, we were able to, hire equipment and furniture and just make it a more therapeutic space for the people that we were working with.
That's fantastic. And so thinking then of obviously you've worked in the prison setting, high secure, secure hospital setting. One of the things that often comes up in our podcast are the myths around or misunderstandings around mental health. So with your experience in those settings, what do you think are the sort of key myths that are still persistent in the context, I suppose, of mental health, criminal justice?
Yeah, I would say that the myths that are still there is they're dangerous. This is the end for them. There is no way out. I work with a lot of patients and even, prisoners as well, who say, well, this is it for me. I've got this condition, got this sentence, and, what do I do next? But actually there is still hope, like, as long as you're willing to engage with the program. Another myth is that, medication is just medication that they need. Just give them medication and they'll be fine. But actually there are so many different factors that contribute to someone's mental health declining to the point where they might need psychological help or vocational support, which is where I would then specialize in. And like I said, with mental health, it's an entire spectrum as well. So of course, I tend to work with those on maybe the more extreme end of things. But if you look at the story and how they came to that point, a lot of the time it started with something very small, and because they maybe didn't get the right support or anything like that, it then sort of snowballed into the situation that they're in now, where it's they've committed a crime, or they're in a space where they've they're high risk and whatnot. So there are so many different myths, but I do feel like, especially in the recent years, there is, because of the information that's being put out there, correct information by professionals and people talking about their own lived experiences, I think that's definitely dismantling a lot of those myths that were previously out there.
Yeah, no, really interesting. I think you highlight a really important point about the role of early intervention as well, and escalation of as you described there really nicely, about something maybe small initially, and then that thing snowball if you don't get the support and help that you need, and often, especially if you're starting off from a position of disadvantage, I think things just escalate. Maybe that sort of brings me on this sort of a slight tangent, but is related. You delivered a fantastic TED Talk last year on empathy, so huge congratulations on that. It's a really engaging. Craig and I both really enjoyed it. So, but can you tell us about how the TED Talk, Jenny, came about, and then for those who haven't seen it, and obviously I encourage everybody just to Google your name, and you don't even have to add empathy, just Google your name and you will find it. Tell us how it came about, and sort of brief essay or summary of your message in that.
So the talk came from, when I started working in forensic mental health, I was met with a lot of questioning, especially from family and friends, saying, why would you work in this type of setting? Like, that's too dangerous, or they're too far gone. And again, because of the lack of education around mental health, and especially when I started working in prison, my goodness, that was a whole entire conversation in itself. I suppose I started thinking about, why is it that I have a different viewpoint of working in these type of settings with the type of client group that I am working with? And I sort of boiled it down to two things. Obviously, education, which through my experiences, so in work experience, doing a bit more research, I have the privilege of having more of an educational background in this type of area. But then also, I've been able to sort of grow and develop empathy for the people that I've been working with, because I work with them in such a close proximity. So I realized those were the two main areas. And I always would say to people that I'm not, especially when you're working in prisons, it can be quite a sensitive subject for a lot of people for various reasons, whether it's a high profile case and whatnot. But I always say that it's not necessarily about the crime that had been committed. With my role, I'm more concerned about how did this person, especially if they come through the inpatient sort of route and potential mental health condition has been identified, how has this person gotten to this point? Right? And how can we support them? Because that's another thing in terms of when somebody is being released back into the community, we also need to think about the kind of support they require so that they don't come back. So my message was to sort of show people that there is a bit more nuance to these type of stories that you hear, these type of high profile crimes that you might see. And it's more about being willing to listen. You might not understand the full story. And sometimes I don't. Sometimes I'm like, well, this doesn't really make sense, but I'm willing to listen. I'm willing to try and understand and try and have a different view on things. And I also wanted to sort of break it down to the point where, especially when it comes to mental health, that anyone could find themselves in this position as well. And also highlighting the point that there are so many different factors, like environmental factors, that, education, where things might have been missed, the lack of information in certain communities. And from a Nigerian background, mental health is barely, maybe now a little bit, but there's still a long way to go in terms of it being taken as seriously as physical health, because they don't have that empathy towards the person who has a mental health condition. So yeah, those were the main areas that I wanted to focus on. And I was convicted to strip it back and just boil it down to empathy and getting people to show a bit more consideration for everyone around them as well, and also for themselves too.
Why do you think there's a lack of empathy when it comes to people who have committed crimes?
I think because people go straight to the crime that has been committed, and that's another thing. It's like, I understand it, and if I was the victim, or if I was affected personally by some of these crimes, I would be thinking the same thing. So I do understand it, but I think people sort of miss, it's almost like they miss everything about this person or this case because they don't have the information, and they go straight to, okay, this person committed a crime, they should go to prison and that's their punishment. But I personally don't feel like we can continue to do that. But if we don't get to the root and to the source of why people commit these crimes, some people, especially those who have an undiagnosed mental health condition or they have a mental health condition, it's just going to be an ongoing cycle. So lack of education around, especially the statistics around mental health within the prison system, you will find this, like the prison that I was in, and also most prisons, you have 1,000+ inmates. And the waiting list that I had as well were over 100. So that goes to show you how many people were, needing input in terms of their mental health. But because of resources, and also it tends to be, they tend to be diagnosed or seen like at a later stage in life as well, which makes it quite hard and difficult as well. So it's something that I definitely had to change in my mindset as well. And that came through working in this type of setting. But I do understand why people might not necessarily have much empathy. But once they do hear the story and why, it might give them a bit more clarity.
And what's the reaction been to the TED Talk?
It's been really positive, and I've spoken to even from family as well, like and friends, just actually understanding, oh, okay, it doesn't actually sound as bad as, because obviously the connotation behind prison or crimes is they've got their own mindset of it, but it's been really positive. And also service users as well, like especially in the community, who sort of feel that they've been given like an opportunity to sort of be seen in a different light. as well, and also my fellow health workers as well who work in these type of settings, who are then able to sort of even use that talk to show that to their friends and family, to give them a better understanding as to why they work with these people, and that it's not just as straightforward as just working with prisoners or just working with people who commit crimes.
Yeah, no, true, very true. So one of the things we often try and do in the podcast is bring it back to research, because obviously we're a research charity. So in that vein then, so if we were able to give you all the money in the world, right, what would be your priorities, do you think? What sort of research questions do you think we should be addressing?
Perhaps looking at, like I mentioned before, the root causes.
Mm-hmm.
So I'm also quite passionate about going into schools. I've worked with PRUs, so pupil referral units as well, where challenging behavior young people tend to go to, and actually get into the roots of why certain conditions, especially even neurodevelopmental conditions as well, which is also an area that I touched in my talk, that are often not identified at earlier stages and perhaps maybe misconstrued as challenging behaviors, where actually they could be autistic or have ADHD or something like that. So that's one. And then also bridging the gap between the services and the community, especially when it comes to accessing people of different cultural backgrounds, because especially working in prisons, I found, and again, there are stats to back this up, where a high proportion of Black men tend to be the ones in prisons, and even section under the Mental Health Act as well. So speaking to families and just people in the community of various different backgrounds to educate them about mental health, provide them with the language, especially when it comes to seeking help as well. So I think a lot of research, I would want a lot of research to be had into that. And also, I think that would definitely support even us as health workers when we are working with families and individuals who have a very different understanding of what mental health is or might not know what mental health is, to just get them to have the right language to be able to access that support. And then also, like I said, in schools as well, which is, I think that's where it usually begins in terms of identifying this.
Yeah, no, great suggestions. I mean, because trying to use that basic science and really to inform all aspects of sort of treatment, care, early intervention, and so on. You touched on there obviously neurodiversity. So in terms of the interventions that you and your colleagues use in the prison or in a secure setting, so what are the effective interventions that you draw upon? And then are they tailored to people with ADHD, autistic people, or whatever, and a whole breadth of other aspects of diversity as well?
Yes. So I can give an example of, working in prisons. And like I said initially, it's very restrictive in terms of even what you can bring in and having to go into the wings. So there were quite a lot of prisoners who had a formal diagnosis and even an informal diagnosis of autism or ADHD, or had sensory sensitivity, especially when it becomes really noisy on the wings and the rooms are incredibly small. So what I did, myself and my colleague, we created like sensory packs that they could either create in a day center, or we could bring that to them to the wings, just as a way to support them in that sort of interim setting. And that was met with a lot of positivity, even from the prisoners themselves, a lot of requests for, our small sensory packs to be made. And also we would get training in terms of the officers. So supporting the officers in identifying these things as well, even if they just had an inkling. Of course, they're not clinicians, but they do have much closer contact with those clients. It will only sort of made sense for them to also be as educated as possible. I know my prison and also the neighboring prisons as well in the UK have definitely put neurodiversity at the forefront. So what happened in my prison was that they had an entire level of the wing dedicated to putting people there who might have more challenging sort of needs. And I thought that was great, because they were able to identify, okay, this is also causing them maybe more distress being in the wing with, lots of noise or not having the right support, so being a bit more isolated. So we're able to sort of work with the governors in that sense. And, as occupational therapists as well, when you do your training, you sort of, you get to know about different conditions in a general basis, but There's a lot of training, specialized training involved that you can, get involved in. So I did the sensory integration training. So I'm a qualified sensory integration practitioner, so I can go in, assess people, and provide them with the right interventions to support them, not just in prisons, but even in the community as well.
I suppose it sounds like, well, it's a sort of microcosm of what happens in the sort of community or broader psychiatric setting, that, yeah, there are these interventions, but trying to get them tailored to the individual needs of whatever the client group is, in this case, autistic or individuals or people with ADHD. But you're obviously, you do have some flexibility in being able to do that and had some success so far.
Yeah, absolutely. And I think that's the key, not just in prisons, but in general. Like I think you've got to be flexible about that approach, because even somebody with ASD, so autism spectrum disorder, might react differently to an intervention that somebody else has.
Yeah.
So all of our interventions require us to be flexible, to see what works, what doesn't. And, that requires us to get to know our service users.
Yeah, it's just obviously person-centered approach, really, isn't it? So that line just struck me was that, so what would you hope then, again, in terms of aspirations, how mental health is treated in the criminal justice system? So what improvements or changes would you like to see, or you think would be beneficial?
Yeah, I think especially when it comes to screening prisoners as they first come in, having that clinical approach as well. So having, I think, like an in-reach team, for example, which, we had I mentioned we have a very small team.
Yeah.
Compared to like the 1,000 plus prisoners that we see, we're meant to be seeing, on a weekly.
It's a big ratio. It's a very big ratio.
It's massive. Yeah. So having more clinicians and healthcare workers be there at the beginning of that process, literally from when they come in the first day, again, just to identify those potential needs, whether it's for neurodevelopmental conditions or for mental health in general, just to make that process much more smoother. Because, the worst thing that could happen is somebody comes into prison, again, they still don't have a formal diagnosis or the right support, and, they get released from prison and the whole thing happens again. It's about trying to break that cycle so that we prevent any further, relapse when they are in the community and, God forbid, they commit another crime.
Yeah. Well, great suggestions there. I think from reading about you attended in 2019 the G7 Youth Summit. That was, and what was that, promoting gender equality or gender inequality, or trying to tackle gender inequality. Can you tell us a bit about your experience of that?
Yes. Oh my gosh, it feels like such a long time ago. But
it's only 4 years ago.
Yeah, a lot happened.
Yeah, exactly. Pre-pandemic.
Yeah, I was part of the Y7 as a delegate, and I was specifically focusing, like you said, on gender inequality. And essentially, the program in itself was, looking at policies across the world, but obviously mainly in the UK as well, around, that particular topic. And I was looking at schools and how the policies sort of affect, the education system, even career as well. One thing that I still remember to this day is just, and it's something that I hadn't realized until I was on the program, was, looking at how even the curriculum at times, it might have changed now, but back in my time, even when you'd open like a book, and especially around careers, you would see that maybe the more maternal or like healthcare related subjects had like a woman there, and then maybe the more like financial had like a male, and there wasn't that sort of representation there. And I didn't realize at the time that was the stuff that I was consuming too. So yeah, it was essentially around, supporting the policies that advocated for gender equality. We went to Paris as well.
You were representing the UK, weren't you?
Yeah. I was representing the UK, went to Paris, spoke to lots of governors, President Macron too, and trying to develop all these policies too. So it was, I was able to even bring in like the healthcare aspect as well, but it was definitely an interesting experience for me, one that I'll never forget.
That's genuinely once in a lifetime type experience, isn't it? Yeah. And actually, I said that was my last question, but completely forgot to ask you about SASA. That you founded. So can you tell us about SASA and what its mission is, what it's for?
Yeah, so like I said, SASA means healing. And I suppose it started off as a project, where I wanted to create a platform. It was a blog at first, where people could talk about mental health experiences, career and mental health. So I'm, again, quite passionate about well-being in the workplace. So it was only sort of recently that I was able to sort of hone down on, what I wanted SASA to be and what kind of service I wanted it to provide. So at the moment, we provide clinical assessments for, just general sort of mental health assessments, neurodiversity assessments. We've started off with the sensory profile quiz. And the aim is to sort of bridge that gap, right, between those who are, let's say, on a long waiting list, because there is a long waiting list for a lot of the neurodiversity assessments. But then also it can be quite expensive if you go privately. So I wanted to bridge that gap in terms of providing people with the education in that sort of medium. And also I found that, especially nowadays with social media, there is so much information that's being fed to people. And again, I get asked quite often, like, what do you think about people self-diagnosing themselves on TikTok, for example, or, reading all this information? And I kind of stand in the middle where I think, we need to move with, how society is going. We can't stop it. So I feel like as professionals, or those who are qualified enough, should be able to provide people with the correct information or redirect them to correct resources. So that's essentially what SASA is about. It's about supporting people in that sort of medium interim position, and providing people with accessible free resources as well, or very affordable assessments that they can use to so wish to go further into seeing what their diagnosis could be. So we're a very small team at the moment, but again, we're literally, there's such an influx of requests for certain assessments, and it just shows how much of a need there is still out there, especially with people having more confidence now to research more about their mental health, their well-being.
And if people want to find out more about SASA, where do they go?
Yeah, so if you want to find out more, you can head over to our website, which is www.wearesasa.com, and then you'll be able to do a very short free sensory profile assessment as well. We're also on social media, so at We Are SASA on Instagram and on Twitter.
Great. Thanks for that. And just before we do the final two sort of unrelated questions, so you've packed a lot in so far into your life. What's your plan? What's the plan for the next few years?
Oh, that's a good question. I definitely want to do more speaking engagements, go into schools, going into communities where they otherwise might not be able to access expert knowledge around mental health specifically. And then I also want to sort of focus a lot more on SASA as well, and bringing more people on board and seeing again how we can collaborate with organizations to access those people who kind of sit in the middle and support them as much as possible with their mental health. And yeah, we'll see. I definitely, especially around like prison work, and there's so many organizations like Reconnect who I don't know if you've heard of them, but Reconnect, their organization, as part of the NHS long-term plan that provides services for those who have been discharged into the community or released into the community from prison, which I think is also an important area that people should focus on, because especially when it comes to accessing jobs and opportunities, that's a whole nother hurdle that a lot of this client group faces.
Great. We always try and have two sort of final questions. And so the first one is, what advice would you give your 16-year-old self?
I would say the advice would be to be patient with myself. And I say this because, and I've said this before as well, you've seen me do, speaking events and TED Talk and all that kind of stuff, but I used to be, and I still am, quite a quiet, introverted person. And I remember like when I was younger, I used to think, oh gosh, there's no way I could do all these, speaking events, or like, even for me to, I remember I got really scared, like even in terms of answering a question in class. Or you remember when they used to get us to read out from a book, like I would always shake when it came to me. So I'll tell myself to be patient and reassure myself that I would grow into the person I am now, and also utilizing my quietness to my advantage. And I think that's definitely led me to a place now where I'm able to use that to my advantage, because I listen more than I speak, which is fine, especially in the field that I'm in as well, where you're meeting a lot of people, having to listen to a lot of people. So yeah, just be patient. It'll all work out in the end.
I think it's a brilliant one. I can see Craig nodding away as well. That describes Craig as well, I think, doesn't it, Craig?
Yeah, definitely. But the only strange thing is that when I was younger, I was more vocal. I was more able to. I was the kid that put his hand up in class. I read in church. I read whenever I needed to. It's only when I started getting older, it's that I started getting quieter, which is, I don't know, it's strange. Like I work backwards. You'd think you'd gain more confidence with age.
I guess because now, like especially now, it's like, we're under so much, I don't know if the scrutiny is the right word, but like with social media and you're seeing people's lives and all that kind of stuff. I don't think we had, well, back in my time, social media wasn't really popping like that.
Yeah. And the other thing, so Jenny, have you read Susan Cain's book called Quiet?
No.
Well, it's really good. It's obviously people, introverts or people who are quieter, and really how they should rule the world type thing. That's not quite what it is, but Susan Cain, it's a great book. It was a New York Times bestseller a few years ago, and she's a new book out now called Bittersweet. But I'm not her publicist, but it's a great book given the conversation we had. Okay, so the last question, then we'll let you go. Is then we ask this again of everybody is, so can you think of somebody living or dead who you would love to have a coffee with or dinner with?
I would say maybe Maya Angelou.
Yeah.
I just obviously, I've read her books and her poetry as well, and I would just love to know, like, or have a conversation with her, because I just feel like any conversation that I would have with her would stimulate my own mind too. So just having a really wholesome conversation with her would have been great. And obviously now I can still read her books and things like that, but she's one of the people that I would have loved to.
Yeah, I mean, absolute inspirational star, that person. So he was really amazing, really amazing. Okay, well, on that really upbeat note, I think that was a great way to end. So on behalf of Craig and I, Jenny, thanks a million for joining us today for a really wide-ranging conversation. So and hope our listeners enjoyed it as well.
Thank you so much for having me. I really enjoyed this conversation.